talk to us about the glaucoma, the hidden scourge of uveitis. Thank you, Dr. Marc, for coming to our country.
Thank you very
Thank you
much.
very
It's a
much.
pleasure to be here, and it's an honor to follow you. You've given fantastic presentations. I'm in fact a uveitis specialist, and I do more retina, so I've learned a lot about glaucoma. But my job here in some ways is not to teach you how to do the surgery or maybe how to treat uveitic glaucoma, although maybe I can give you a few tips. It's more to be able to put it into the appropriate perspective. If you could open my presentation, or maybe I'll do it. No, 1 second.
Audiovisual, please, Dr. Marc's presentation. Did you load it, sir?
Yep, yes, there it is.
Okay.
So these are my disclosures. They're not really important with regards to this. And I thought I would start with two cases. So the first one is a 48-year-old man that was seen, I practiced in Switzerland. He had high IOP and granulomatous uveitis in both eyes, even off steroids. He had 2 GAT procedures, one in each eye, and yet the pressure remained high. Now, in this part of the world, you probably would recognize what this is because this is CMV anterior uveitis. It responds very nicely to antivirals. In fact, with acyclovir, his pressure dropped. And it shows how we do need, as was mentioned before, collaborations between glaucoma retina specialists, definitely between glaucoma and uveitis specialists that is required. The second case is a patient that came to see me with HLA-B27 uveitis. 2 years before, she had cataract surgery. Everything went well. She was placed on an anti-TNF agent because she had active disease. Too expensive for her, she stopped. And whenever she had a flare-up, she would put herself on steroids for several weeks. When she came, she had hand motions in the right eye, 0.5 vision in the left, high IOP, active uveitis in the right eye. We weren't able to get a visual field in the right eye. There was definitely a limitation also in the left. And if we look at the RNFL in this case, oddly enough for the right eye, there still seems to be a neurofiber layer. But once the uveitis is gone, all of a sudden we have nothing. And I think this is one of the other aspects, is if you're dealing with uveitis patients and you do your standard exams, some of them give you a false sense of security, in part because we get retinal edema. And that retinal edema will make it so that your RNFL doesn't really give you the full picture. So we all know glaucoma is a chronic progressive disease. We can monitor intraocular pressure, optic nerve, and the RNFL, as well as other modalities. And in uveitis, it's associated with essentially the presence of inflammation. And for ocular hypertension, we usually use 21 to 24 as being the threshold, but is this in fact correct for uveitis patients? And what I'm going to try to tell you now, out of studies that were done in the recent past, is that in fact you should be extremely sensitive to the fact that if you have inflammation, any increase in intraocular pressure may already give you problems. Of course, one of the key elements is the treatment we use. We have to use steroids, usually at the very beginning. Our role as uveitis specialists is to try to switch them over as soon as possible to immunomodulators if they have persistent disease. But as I've just shown you with the second patient, is we can't put them on good immunomodulators, but if they're too expensive, they stop and they go back to what they received initially. And corticosteroids, yes, can give you increased pressure. They will do it in all patients without a patient being a steroid responder. Steroid responders with 1 drop will go up into the 40s. It usually takes about 7 to 8 weeks, but can occur as soon as 3 weeks of use, for example, with dexamethasone. The pediatric population is a lot more sensitive, and you have to be a lot more careful. If you go beyond 2 drops, they can have increases in pressure. And if there is oral steroids being used at the same time, then the risk is much higher. So 31% over a period of about 7 to 8 weeks will have an increase in pressure, and about 10 to 15% will even go above 30. And if you follow patients long enough with uveitis, at some point, there will be an increase in pressure. And it wouldn't be surprising that within 5 to 6 years, these patients will be over 21 millimeters of mercury. And as I'll show you in some from other studies, in patients that were followed in the MUST trial that used the Osidex in one eye and followed patients with systemic therapy in the other, any patient that had an intraocular pressure over 16 had a risk of developing glaucoma. Now, increase in the number of drops certainly will increase the risk of having a pressure rise. Certainly, if you go to higher numbers, for example, 5 to 7 drops per day, that rate can go up, the relative risk will go up to about 8. Now, there isn't much difference in terms of the need for control of pressure with drops, whether you're using a periocular injection, well placed, without any reflux, whether it's an intravitreal injection or dexamethasone drops being placed topically. There is an increased risk by about 7 to 8 weeks, as I've mentioned, and more of these patients will require, over that initial period of time where they need to be followed, the use of drops. There are other factors, if there are posterior synechiae, anterior synechiae, or the length of treatment, that increase the risk of developing glaucoma, so that has to be taken care of and taken into account. And these are the results of a study that in patients that were followed with either systemic or the implant, the MUST trial. You'll notice that a number of these patients were already on glaucoma medication drops at the very beginning of the study, 13% in the systemic group, as 17% in the implant. They had good cup-to-risk ratios, and in fact, the visual field mean defect was 4.8 to 5.7, a mean of 5.2. I mentioned that because after 2 years with systemic treatment, you see that you have about 26% now that have developed a pressure increase that requires treatment in the control group on the systemic side, where we had only 13% initially, and 69% when an implant was placed into their eye. So the use of an implant certainly increases the risk of glaucoma. That's well known. There's also an increase in the need for surgery. And this is progressive over time, particularly in the group that receives an implant. You can expect that glaucoma surgery will be required somewhere between 12 to 18 months after entry into the study. Now, that's not the only problem, because if glaucoma develops in uveitis patients, they tend to progress more quickly. As you can see here, the relative risk for uveitis glaucoma patient to be a rapid progressor is 1.9 as compared to a chronic open-angle glaucoma, and the rate of progression tends to be faster. This is this study that was done in Britain. If we look again at the MUST trial, you'll see that, in fact, the glaucoma group had a mean visual defect at 2 years of about 12, when initially we were at 5.1. So that represents about a progression of 5 dB per year over that 2-year period, while in the non-glaucoma group, the progression was about 0.5. So progression is quick. Patients need to be followed very carefully. But if they're well treated, as was mentioned earlier in the previous presentation, you can in fact stabilize the situation as long as the patient is followed sufficiently. So there is a higher rate of progression. There's also an increase in the cup-to-disc ratio. And for that reason, a group of uveitis experts as well as glaucoma experts got together about 2 years ago, and we've been discussing since what would be the best way to follow patients. Well, at this stage, we're all agree that tonometry is important at each visit. Gonioscopy should be done on all uveitis patients at least once to get an idea of what the angle looks like, and whenever there is a recurrence of inflammation, because you can accumulate either synechiae, granulomas, or otherwise fibrin that goes into the angle and may compromise and make the uveitis worse. Similarly, I've shown you RNFL can in fact give you a false sense of security if there's active disease, and so you need to establish a baseline from which you know more or less what the situation is when there is no uveitis present in that eye, and then should be followed at least on an annual basis. Similar visual field should be done frequently enough to get a baseline, and then depending on whether there are any signs of glaucoma or visual field changes or NFL changes, then you should go from doing it annually to more frequently. And finally, optic nerve head photos are always useful. They're easy to obtain, and I think in most settings should be done. With regards to therapy, ocular hypertension in uveitis is not 20 to 24. It's a lower pressure. Any increase in intraocular pressure associated with the changes that would typically appear in glaucoma should indicate the presence of ocular hypertension, and you should treat aggressively to reduce that pressure to the lower teens, essentially as a bad glaucoma patient, because they progress more quickly. Similarly, and this should probably best be done in close collaboration with our glaucoma experts. With regards to surgical therapy, we don't really know at this stage what the best approach is. If you have a person that knows how to do trabeculectomies well, I think it's a good procedure. Certainly if the patient has no inflammation, the inflammation has to be under good control. MIG certainly function. Ceton placement is certainly something that should be considered if it's active disease or if other modalities have failed, and there are different ones. AMED and the Paul valve seem both to be very good. Close follow-up is required. Treatment of the inflammation is naturally required. And the exact role of SLTs or excimer trabeculoplasties, that isn't quite really defined at this stage, but certainly would benefit from further research because they're non-aggressive, non-inflammatory, and may be good ways to control pressure for the very same reasons that were discussed earlier today. So in conclusion, glaucoma is an unsolved issue really in uveitis, one that hasn't received much attention. Progression is fast, and we need to find a combined solution that will work for the future. The loss starts at lower intraocular pressures than might appear in chronic open-angle glaucoma. We need aggressive therapy, and IOP increase is not just due to steroids. So what is going to be your approach in uveitic glaucomas from now on? I leave that up to you. Thank you very much.
Thank you very much.
For those of you who are interested, there is a course being organized early June in Bruges in Belgium that will tell you everything about the basics of uveitis management, and we'll be talking about glaucoma also.